All right, thank you. I'm super happy to be here. I was waiting for these guys to invite me to come talk about community health assessment, and they finally did, so I'm so happy because Shirley's right, and of course I was hugely inspired by Shirley at the health department and feel really privileged to be here at the School of Public Health, really bringing a lot of my public health practice to academia, so to teaching students, and really doing community health assessment in maybe more academically rigorous ways, and I would argue ways that might be more meaningful to communities. So what I'd really like to do is share with you what is community health assessment. I know those of you who are public health practitioners probably know this stuff really well, but we're trying to do some innovative things here at the School of Public Health and doing community health assessment in more engaged ways and creating data that might be more meaningful than the traditional data that we look at in community health assessment. So I'd like to tell you about community health assessment, and I'd particularly like to share some examples of the project I'm working on right now that's leading me to get no sleep this week. That's just really exciting, and it might give you some examples of how these tools in community health assessment, these methods, these approaches might be useful to you and your groups. Does that sound good? Okay. So, and then at the end, actually, and so I asked Wesley and Goody to pass out my slides for what they're worth, and then this worksheet. So I'm hoping you all also got that worksheet. I was hoping that within your groups, this worksheet activity might be useful in starting to think through what kinds of data might be useful to me, what kind of approaches might I employ to better understand the needs and the assets of my community, recognizing that your communities are all quite different. I learned from your applications kind of what the interests are across the groups, and they seem to vary by geography and age and that kind of thing. So I'm going to start out talking about why we do community health assessment. What is it about communities that's of interest to us? And then I'm going to share with you something called Mobilizing Action for Plannings and Partnerships. Has anyone heard of this besides Shirley? This is MAP. So anyone who has a public health background has been exposed to this planning process that employs community health assessment activity. And then I'm going to tell you about my project, and we'll try to engage in this small group exercise. So one of the things that really excites me about community health assessment, it's one of 3 core functions in public health. So it's what we do. And what we want to do is to really understand the community in which we're trying to improve the population's health. And of course, this idea of population health has just been broadening and broadening over the years. So now we're really talking about wellness. We're really talking about engagement. I think that's a really great evolution, that we're leaving somewhat disease behind to talk more about what does it mean for a community to be healthy. But I like to share this slide and the slide following it, because at our National American Public Health Association meeting this year, we were greeted with these huge signs, these billboards of children's faces mostly, and this information that basically where you are born affects your life, right? Your life expectancy and your quality of life. And this is in California. In Boston, they're doing a similar thing, and my plan is to convince Shirley to help us do this here too, because of course we have not only the data to demonstrate differences by life expectancy, but we have the racial and economic segregation that's really behind this, unfortunately. So the campaign when we were at our conference this year really was that that place matters. And this is something we've been talking about in public health for a long time. And we're not exactly sure how place matters, but something about your community influences your overall health. And that's typically measured by death. And so life expectancy is a measure of death. So how long might you live? And this suggests that basically, depending on your zip code, your life expectancy is drastically different. And this, of course, we have these data in Chicago. We just don't have them in giant billboards as nicely as they do in California, but we will. It's a matter of time. These are some data that the health department, where Shirley and I come from, produce. And this is looking at a hardship index. And a hardship index is something that actually our chief of epi at the health department likes to use, because it's not just education, it's not just income, it's not just race. It's a matrix of all of these things that seem to influence poor health outcomes. And when we were at the health department, we would map health outcomes across. These are our 77 community areas for our Rockford friends, right? I think most of the groups are actually pretty proximal to where we are, except for Roxford. Maybe I'm wrong about that. But when we think about Chicago, we think about these 77 community areas. We're, of course, quite segregated by class, by education, by race. And we see poor negative health outcomes in those community areas that are poor, that are, have low rates of high school graduation, that have unemployment, these kinds of things. And so it leads us to this conclusion. It's kind of, I like to say, the duh conclusion, right? That place matters, that where you are born, live, work, and play, and now they've added and pray, matters, which is why this group is so significant. And I'm thrilled to be invited to get to say something in front of you, because increasingly we're really thinking that it's not necessarily your individual characteristics that matter all that much. It's really your context, this environment, this community. And it's these social determinants of health that we need to understand to really understand disparities in health outcomes. So differences in asthma and diabetes and life expectancy and these things that we're really interested in. And this is probably all very familiar to you, but it grounds me in why do we do community health assessments? Why do we not just add up the health of all the individuals in a community and say, all right, this is what the community looks like? And the reason is that there's something about that context that's of interest to us. And there's some interesting ways of trying to describe that context, that community. And you know, I tend to do community health assessments on geographies. So like I described, we're in South Lawndale, which is referred to as Little Village from the residents. It's a predominantly Mexican immigrant, poor community right there, like not far at all from where we are, for those of you who know Little Village. But a community health assessment, of course, can be done in any kind of community. So a congregation, a church community. They're often done at a state level, and then that information is, of course, given to the federal government to make some decisions on health priorities. When Shirley and I were at the health department, we worked on city-level community health assessments, which is always really challenging and kind of funny to try to assess the health of nearly 3 million people that are diverse as we are. So I actually really like doing these smaller community health assessments because you can really understand, I think, the health issues of a smaller community like Little Village. So a community health assessment is just what it is. It's really trying to assess what are the needs of this community and what are the assets. And we actually added this word asset only recently, only I think in 2000. So we now like to refer to community health assessments as community health needs and assets assessments, suggesting that in the past, we basically made these laundry lists of everything that's wrong in the community, and we didn't identify all the assets. And without those assets, we have nothing to build on. So another kind of duh conclusion that we came to, but we started really thinking about, well, what are the assets and how does that relate to a community's capacity to make change? So some of the reasons why a community health assessment might be done, I just gave you some, right? We do these at the local health department to try to make some decisions on some health planning decisions, where to invest money. For sure, in situations like you're in your groups, you might do a health assessment to better understand some phenomena about your community. So I know one of the groups is interested in the Affordable Care Act, the impact of the Affordable Care Act on their congregation. So you need some information. What's the baseline? What do people know about the Affordable Care Act? You probably want to know something about the experiences of people interfacing with the healthcare system. We hear, particularly from low-income populations, a lot of distrust of medicine generally that leads to barriers to care. So there's all sorts of reasons why we might do a community health assessment. Increasingly, we're doing them at these smaller levels, which I think is really exciting because we're able to work in partnership with, for example, faith communities, gather data that might be much more meaningful to us, and then through our partnership we can interpret the data so that we better understand health. And I'll see if I can make that more clear in a second. So those of you who are not public health people might not be familiar with this kind of model, but assessment's one of our core functions in public health, and to the right are essential services. And when we do a community health assessment, we basically want to understand what is the health of the people who live in this community. What do they think about this? So what are their perceptions, attitudes about health? And what does their context look like, or their system? And that's when we use these 10 essential services to really think about, so what is the system in which they live and how does that affect their health? And here's our mobilizing action through planning and partnerships. This is something that was created by the National Association of City and County Health Officers, so NACHO for those of you who aren't public health people. And this is a planning model. It's not the only one. It happens to be the most commonly used one, so I like to talk about it. I also think it's one that we can really enhance through better community engagement and basically better qualitative methods. So I'm going to talk about quantitative and qualitative methods in a second. And quantitative methods are really those that produce numbers. We quantify, we count. And qualitative are those that really produce something other than numbers. So this is usually language or photographs or dialogue, images, mapping. And of course, these are the stuff that we are more recently having really cool tools to be able to do. So we're able to really easily collect, for example, focus group data and transcribe it and try to understand the themes and then map the themes on a map. It's these kind of qualitative methods of community assessment that I'm going to introduce that might be most interesting to you because they're kind of and available for us to use. So anyway, this is the map planning process. The CDC just came up with a new one, so I'm trying to decide what I think about it. But the map planning process suggests that you engage in a community health assessment only when you're really grounded as a group and you have a vision. So you're a beautiful example of this, of groups coming together. Do we have a problem? Well, what's our goal? What do we want to change? And what do we need to know in order to make that change? And so this image basically suggests that through this planning process, which basically starts with organizing, getting together, again, being on the same page, and going through a visioning process. And we've done this at the City Health Department. We did this about violence prevention, what feels like a million years ago, when we wanted to get on top of violence in Chicago. And then we engage in, this says 4 map assessments. And these arrows around are the 4 map assessments. So I want to talk to you a little bit about what those are and importantly, what those data are. I'm going to out myself as a huge data geek. So I might get more excited about data than other people, but I do want to introduce kind of what's out there for us to understand our communities. And then once we have the data together, we really identify, so what are these strategic issues? What are these core issues that we need to change to improve the health in our community? This is a stage we're in Little Village that's making me not sleep at night. And then we identify goals and strategies to really make change. So what? And importantly, community health assessments should be done to make change. And I think, unfortunately, all too often, data is collected from communities with the intention of making change, but something happens. We didn't get the funding, or we weren't able to actually make that change. And of course, that's hard on communities that are pulled in to big collaborative efforts, and then they don't see the fruits or the results of that. So these are our 4 community health assessments. This first one is the one I want to kind of emphasize today, which is data that identifies the community's themes and strengths. And this is towards a deep understanding of the issues. And what I like to explain is it's really hard to get a deep understanding of issues through numbers, any way you look at them. And actually, we really tried this at the health department. We were looking at access to health care for marginalized populations across the city. We looked at the numbers in every way we knew, but we still couldn't understand. And so it lends us to a different kind of data, a different kind of research, which is simply talking to people through maybe academic, rigorous ways, whatever language I need to use to convince people of this, but really talking to people and that being your data. So that's this first kind. So you identify what are the community's themes and strengths. Right now in Little Village, anyone who knows Little Village might know what we're learning, but it's fear of safety. It's fear of being undocumented, leading to barriers to access to care. It's a concern about gender inequality within families, domestic violence. And these are things that we might see hints of them in our quantitative data and our numbers, but not in the way that we're hearing it from communities. So it's a valid data form that really has the same credibility as numbers, but in our discipline in public health, numbers kind of trumps, unfortunately, but we're making change on that. So, and this second bullet here has to do with these numbers. And we are data rich, especially in Chicago. We are data rich. Because of our public health surveillance systems, because of the United States Census, because basically we're a dense urban environment, we have, my students will tell you, they are drowning in data that we're trying to make sense of. And I'm going to explain a little bit about what that data is in a second. So we have this qualitative language, photos, conversation kind of data, and then we have these numbers. And these are really the two major functions in a community health assessment to try to understand, so what are the health issues? And then these last two, one is to really understand the public health system. I have to say, the more I do this work, I say the public health system plus, you know, education, plus social services. That it's really more than the public health system. It's that whole context in which people live that we try to assess. And we do that through asset mapping, like I said. So what's in the community? What resources do people have? And how well is that system working? The people in Little Village are suggesting the Chicago public school system is not working well for them. And then we do what's called a forces of change or forces of trend analysis, which is talking to our community partners and really asking the question, so what? What's going on? What's influencing these? What are the major issues that are influencing health in our community? So some people say immigration reform. Some people say the economy. Some people say discrimination, racism. These come up in every forces of change, that these influence how we behave in terms of our health behaviors. So classic health behaviors like smoking, eating well, using protection, and going to the doctor, so health-seeking behavior. So that's MAP. That's kind of the somewhat boring overview of what we do in a community health assessment. But these are the kinds of data, and this is what I wanted the groups to kind of consider that might be useful to you in the work that you're engaging in. So what we typically do across these 4 systems assessment is we collect data and we look at existing data. So this first point is this existing data that I described we're drowning in. Now mostly this is census data and public health surveillance data. So on your worksheet you'll see there's all sorts of variables that we can explore in the census. And actually in your applications to join this, I noticed everyone described their communities in terms of some census characteristics. So race, income, education, I think age, a group's interested in aging population. So this is, this kind of gives us the description of our community, or we like to say it describes the composition of the community. And that's actually where we usually have all sorts of questions. So in Little Village, we have a really huge young population. It's predominantly male. And we also happen to have a huge gang problem in Little Village. So we start using the census data to try to understand, well, what might be the health issues. They have one of the highest rates of sexually transmitted diseases in Little Village. So our census and our health data start to make some sense to us. So what might be some issues here? But then we engage in original data collection, and that's all this other stuff. You can employ a community health survey. There's lots of good examples of this. We do one at the health department occasionally. We've done this in Little Village, and it's an online survey using something like SurveyMonkey, except that it's our university SurveyMonkey. And this is really asking people about their health. So we know something about their health because we have the records on disease and hospitalization and death. But we really don't know perceptions of health. So on a scale from 1 to 5, you know, how healthy do you feel? Do you feel more healthy than in the past? What are your health priorities? What are the barriers that you feel? So this is actually quantitative data in that they're filling out a survey that we'll then analyze, but it gets us a more in-depth picture of health in that community. So that's one kind of data. And then these other kinds, this is interviews and focus groups, and most everyone knows about interview methodology and focus group methodology now. But we're employing it in what I'd like to think are some pretty rigorous, interesting ways, where we identify in communities who are the most vocal groups of people, and we conduct focus groups within that group. And it's basically an opportunity to allow that voice to be heard. From a research perspective, because I'm a researcher, sometimes I have people say, well, you don't want a light group, you want a lot of different people around that group. And that is one idea, that might get at the more diverse voices in the community. But having done this several times, I'm a big fan of the coherent voice. It's an articulated voice from a similar group of people who've thought through these issues, who've sat around the table together. And if we get this data in a research context, it's an opportunity to really make that voice public and loud and a data source that is on par with the quantitative data.
Could you give an example of that?
Yeah. Can I ever? So in Little Village, we did 6 focus groups in the past 2 weeks, and my students conducted them, which was an interesting exercise too, because we train students in collecting focus group data. And we have all sorts of problems with our students not matching the demographic characteristics of our population of interest. And that's a problem. And we face that problem by really identifying who we are, and we are not residents of Little Village. And we do like to match by gender, particularly in a community like Little Village. But there's some characteristics we can't match by. Age is one of them. Anyway, we just last Wednesday did a focus group with gang members who are affiliated with Ceasefire here in our building in Little Village. So these were men between the ages of 18 and 36. Actually conducted the focus group in the middle of that giant storm last Wednesday, so I was listening to the focus group, and the thunder somehow made the data even more meaningful. But this group of men really talking about racial profiling, what we like to call identity threats in academia, which is really this difficulty of presenting themselves as a productive citizen when people judge them based on how they appear. So gang members. We had mothers as part of a running group. We had a youth theater group. We have a youth violence prevention group. We have 2 ESL classes, so English as a second language class. So what we're trying to do is take advantage of existing groups of people in the community. And I do point out that some researchers would say, so these are like groups, these are homogenous groups, and usually in research you want to randomize and you want diversity. But I think in a community health assessment, when you're trying to understand what are the strengths of the community, what are some of the barriers to being healthy, I think these existing groups work really well. I'll let you know, though, how it goes this weekend. So we do focus groups, and then the interviews, you're probably quite familiar with this. This is with key stakeholders in the community. So executive directors of federally qualified health centers, some teachers, some violence prevention community organizers, that kind of thing. And we ask them the same questions. So what does a healthy community look like? How healthy is your community? What are some barriers to being healthy in your community? What are some assets to your community? This is a Mexican immigrant population that has lots of family-oriented assets that actually we even see in our quantitative data. People refer to a Latino paradox, that despite poverty and low rates of education, and stress, they tend to have favorable health outcomes. So maternal and child health outcomes. So low rates of infant mortality, low rates of overall mortality. So it's actually quite interesting, but we hear through the interviews and focus groups this allegiance to family, this eating at the table, these things that don't come up in our data collection systems that we find really valuable and interesting. Now, actually, in one of our youth groups, they said the exact opposite. Mom hanging over me all the time is not helpful to me. And actually, that's actually emerged as a really interesting theme that, particularly in Little Village, which does have one of the highest homicide rates, and it is a community that experiences a lot of daily violence and a lot of stress around violence. And mothers, and I am one of 3, so I totally get this, keep an eye on their child, and they're really restricted in terms of mobility. So we heard a lot of youth say, I was allowed to cross the street, go down that block, come back, and come back home, and my mom would watch me on my bike. And that was my world. And what we're starting to hear is that was mom trying to protect and love and care for that child. But that does affect that child's ability to socialize with other children, to be mobile, to be active. And of course, we're seeing that in our quantitative data systems in terms of rising rates of obesity. It also keeps a lot of children inside behind the TV, which we know is problematic in terms of overall health. So that's interview and focus groups. And we also do observation and mapping. And I want to talk a little bit about that, basically because it's just so darn interesting and fun. And we refer to this as shoe leather epidemiology, right? So you're walking and your shoes are wearing down because you are collecting data through observation. So what can we see in the community that's of interest to us in terms of health? And I failed to mention that we're doing this community health assessment with 6 community-based organizations in Little Village. And that should have been the first thing that came out of my mouth, because my biggest critique is mostly these community health assessments are done by public health geeks like me who aren't a part of the community, and then we lack that credibility and that insider information. So we are very much guided by our 6 partners who are telling us what to observe. And so that has been very interesting. So they were interested in observing gang graffiti, for sure. litter, the availability of trash cans, how full are trash cans, soda consumption was something of interest, so we started looking into and this is, we're playing around with this. There's all sorts of inventories out there, but we were really trying to understand what if you tailored your observation and mapping to one community? What would be of interest? What we ended up mapping are things like bars on windows and fence height because of what started emerging out of the focus groups and interviews about this safety. I need to be safe, I need to be inside, and very much their homes appear of that nature. One of the focus group participants said, we've built a prison community that we're keeping our youth inside as prisoners to keep them safe. So that lends to, actually all the observation data I just described are actually kind of deficits, not assets, right? Litter and bars and fences. We're trying to do deliberate asset mapping, and actually there's been a lot of work in Little Village on asset mapping because it is rich in community assets. And so I'll show you a couple of examples of that. I did want to talk about photo voice. Has anyone heard of photo voice in this? So this is an increasingly utilized method for assessment. And I didn't use it this semester, but I'm a big fan. So it's really using photographs as data. And so it's engaging your community partners to take the photographs and then use the photographs to try to understand health. So this is utilized a lot with youth. So in Little Village, I imagine some of the pictures that might come back might be pictures of the extent to which they feel restricted in their homes or restricted around mom and how that might affect their overall health. So there's a very specific kind of approach and methodology to that you're seeing more and more in community health assessments because it's easy, right? You have a smartphone, you upload it somewhere, everyone is able to share the photos, you download them for community meetings, pass them around and really talk about them. It's a little bit more than talking about them, but it is, that's the general premise. Do we have questions before we jump in? So those are kind of the approaches that you take in a community health assessment. So you have these numbers that describe, and then you have this qualitative stuff that helps you to understand. And we like to say we're employing mixed methods because these are two different kinds of data, and we're really trying to say, now how do I better understand it? So for example, Little Village, from the census, is actually the most dense community in the city of Chicago. So that's crowded housing. So, and it's multiple families living in small units. There's reason for this density in housing. But we're hearing that in our interviews and focus groups too, as problematic, as loss of privacy, having to share small resources, that kind of thing. So that would be an example of kind of mixed methods analysis. So here's the data. And I did take a peek of where everyone was coming from to get a sense of what kind of data might be available to you. And I know Rockford less, but the truth is in Illinois generally, we have a really robust public health surveillance system. And increasingly, we tie that data to geography. So census tract, community area in Chicago, zip code, county. We have lots of really good county data. And these are the data that we would look at for our existing data that might be of interest to us. So birth and death records, two kind of classic kinds of death data are overall death. So these are death rates, number of deaths over the population, and then infant mortality. Of course, infant mortality is kind of this classic flag of what is wrong in a community if in the United States you have high rates of infant mortality. We ask why. And then morbidity, which is, of course, disease data. So the incidence of disease, how many disease, who's hospitalized, who's receiving screening, who's getting treatment, what kinds of treatment. So these are all data available to people depending on what their interests are. I'm starting to avoid some of the disease data for the more social determinants of health data. So tell me more about crowded housing. Tell me more about education, that these might be more useful to us to change health at the community level than discerning the difference, again, in disease category, because these social determinants of health affect all the diseases generally. These maternal and child health indicators, like I said, infant mortality, these are red flags for something wrong in a community when women are delivering babies early, when they're not seeking prenatal care, when they're engaging in risk factors during pregnancy like smoking and drinking alcohol. These are public health, what we like to say, red flags for intervention. So there's birth and death, there's disease, there's these maternal child health stuff, and then there's health behavior. And this is where we do need more robust data, but we get some sense of how the health behavior people from what's called the Behavioral Risk Factor Surveillance Survey, for those of you who aren't. So there's some problems, of course, with self-reporting negative health behaviors, right? I mean, when you're asked, do you eat 3 fruits and vegetables a day? Most people pretty much know that's what they should say. So there's some problem with validity of that data. But it tells us something about the health behaviors they engage in. And you know, despite the problem with that kinds of data, when we look at the data for Humboldt Park, we see higher rates of young 8th graders marijuana, drinking alcohol, than at the state level. So there's something there. So even if there is a problem with reporting, we saw that there might be a problem with risk behaviors. And I have an 8th grader, so that kind of stuck with me. So one of the reasons I'm excited about community health assessment these days is that with this more focus on these qualitative methods, we're using people and using photographs, it's a better opportunity to allow that community voice to be heard, to create awareness for inequities across place. And I know you're organizing around this topic of health equity in this institute, and I think community health assessment can be really useful for this is what we see hearing, this is what we're hearing in our community, and how is it different elsewhere and why, and that kind of leads to these issues of health equity. It's also an important opportunity for community-based participatory research. Have people heard of this term, CBPR? We're talking a lot about it in public health now as a much more useful way to engage in research, to do it in partnership with communities, similar to what's happening in this institute, but really having community health assessment be a research. What's really trying to understand, our research interest is community health. So now we have some data, we can describe it, and we share it with the community. And that's actually what we're doing this weekend, is we're sharing the data back with the community. And this is a principle of community-based participatory research, is that you don't take data and walk away. And this is actually how research has been done throughout time. We refer to that as helicopter research. So the researchers hover over a community and extract the data and run off and find it really academically interesting and publish it in manuscripts and present it at conferences, and the community is left with what was that all about? And so what we're trying to do is continue to be a part of this community by sharing what we're learning back with the community. And this is where I'm sure some of my students are losing some sleep too, because it's hard. It's really hard to both translate research findings to the general population, to do this in ways that are humble and relevant to the community, and to allow for feedback. And so what we're really allowing ourselves for is no, you don't have that right. You know, that might be coming out of your focus groups, but that's not right. And that's what we want to hear more of, that kind of thing. When do we have things right? When do we not have things right? So we call that member checking, where you check your findings with the community from which data came. And I have to say, in the focus groups and interviews, we heard that loud and clear. What are you going to do with the data? When do I get the results? What's going to happen? So I think this is also the community saying, you know, we have to work in partnership. If you want to understand our community, I want to know what's in it for me. So here's just some examples of asset maps. So I jumped around a little bit here because I get kind of excited about the qualitative stuff. But when we collect data by shoe leather epidemiology, it lends itself to easy mapping. And assets can be things from, of course, religious communities, public health systems, schools, transportation, those kind of like infrastructure things. But they can also be assets that the community identifies. So in Little Village, there's like some mothers groups that are assets. And we can actually map kind of where these mothers groups are that kind of watch over the community. And mapping is one of these tools that has just become so cheap and easy and everyone can do. So I hope next semester we'll actually even have mobile devices so we can immediately kind of give coordinates. And by the time we get back to our classroom, we have a nice map. And maps, of course, people like maps. It's a really good way to show data, and people hate numbers. So I should have shared with you what we're sharing this weekend. We've basically taken all our numbers and we are graphically displaying them. We're using something called pictograph, which I have to say my 7th grader told me about, but don't tell anyone that. But it is a graphic way of trying to share data, and it is addressing this fact that people are kind of data phobic. And so if we come in talking about rates and incidence and prevalence and disparities, we lose the conversation. But if we come in saying these things are going up, these things are a problem, and that's kind of what our graphs look like, kind of up, down. And we also deliberately focus on assets. So I wanted to show you a couple examples of asset mapping that might be useful to you, but also are good examples of demonstrating how to think about a community's health from multiple ways. So are people familiar with Southside Health? Some of you are in, I think, these areas that they're of interest, no? Southside Health, and then what's your health code? This is actually, I'd love to claim any kind of association with this group of researchers. But I don't have one, although I talk to them all the time about how can I get more involved. Because this emerged out of University of Chicago. I, of course, like that it doesn't say University of Chicago anywhere around it, because it's a partnership with community organizations and really trying to identify assets on the south side of Chicago, both towards kind of calculating what kind of assets do people have available to them, but also having this be a resource for people. Of course, that's always a problem, right, with the digital divide, and not everyone has internet. But here's just an example. So those of you who know Chicago know these are community areas on the south side, somewhat southwest side of Chicago. We're trying to talk them into moving north so that we can hit the all of Chicago. So does someone know one of these community areas and want to pick one for me? Washington Park. And then I'm going to choose the services from the list below. So what am I interested in? Groceries. Where's groceries? Is that on here? Should be, right? Retail? There we go, grocery. So I can, liquor stores, right? We're interested in liquor store density in Chicago. What else? Pets. There's lots and lots of pet stores in Little Village for some reason. We're starting to be interested in that. And then I come down and I see where these assets are in Washington. It's actually a bigger geographic unit than Washington Park, isn't it? So you see the community areas around it. So again, I'd like to take credit for this work. I show it to show an example of how technology now makes it so easy for us to look at what our community resources. This group of people, is anyone familiar with Southside Health? Okay, so jump in if I get anything wrong, because I really know them from afar. But they're employing youth to collect the data and really deliberate attempt to keep the data up to real time as close as possible, which is, of course, a problem with these really cool things is that they happen at one point in time and the data is old and you can't do anything with it. I want to show you one more. This is an attempt to work with Shirley on this kind of thing, because this is a effort out of Boston called What's Your Health Code, and it's a deliberate attempt to get people to think about how place affects their health. And Boston has similar issues around segregation by income and education and race and ethnicity and related poor health outcomes, suggesting that it's not individuals as much as it might be place that influences our opportunities to be healthy, which is really that definition of health equity. Has anyone seen this website? So anyone who's it's real, people who don't like a lot of movement on their screen, this is going to bother you. But this is a graphical depiction of Boston, right? And anyone know Boston well enough to choose an area of interest for us? Huh? Rosendale. So you choose Rosendale, and then we're going to actually fly there like we're a bird in a second. And this is, this is an effort on discerning communities' health needs and assets. See what I mean? This would make my sit down. So we fly to Rosendale, And it gives us some data. Okay, it gives us the zip codes in Rosendale, which are quantifiable. This is my dream in Chicago is we do something like this, and then we give the quantifiable data we have available from the census and the health department, and then we give this narrative data that focuses on assets and a deliberate kind of conversation about how place affects. So those of you who can't read this says, Rosendale is home to Boston's first smoke-free housing development. That's an asset. This is good news for some residents because it's estimated that exposure to secondhand smoke can cause lung cancer, deaths in non-smokers, and several studies show it increases the risk of heart disease. By 2013, all public housing developments in the city will be smoke-free, but until then, many people will continue to live in places where secondhand smoke is a problem. Health can be impacted by the environment outside or inside a home. So it's an example of trying to make data useful to people, so we're not just putting up a bunch of numbers that kind of lack relevancy to the community of interest, and to focus on some assets. So the way I read that as a public health practitioner is Rosendale probably has one of the highest rates of death from smoking, cancer, and heart disease. And they're sharing that with you, but also framing it in some assets that Rosendale has, which is this move to smoke-free housing. So this is the kind of technology that is available, increasingly will be available in the city of Chicago, but that's using data to really think about how communities impact our health. So a couple of things about the project I'm working on, although I shared some of it with you already, and then I wanted to see if we could talk through what data might be useful to your group. You know, what are your interests? What kind of data inform that interest? Where do you get them? And what approaches might be useful? So I described this partnership in Little Village. We have 6 community partner organizations that all have something to do with health, but we kind of deliberately chose them broadly. So we have a federally qualified health center. We have a youth violence prevention center. We have Erie Neighborhood House, which is housing rights. We have an organization called Latino Progresando, which is really a legal advocacy rights. We have a faith-based community who I wanted to have here today, but they couldn't be here, and who I'm trying to get to do this institute next year, because I think this would be really good for us. But we've been trying to, through a method approach, try to understand health in Little Village while employing students, and that is kind of the, what makes this different is it's part of a course I'm teaching in community health assessment. But the challenge was, can we teach community health assessment while engaging in a community health assessment activity, and collect data that's useful to organizations, and that was the key. And some of this comes from the health department, where we did some really interesting work that despite our efforts, it was hard to make it useful. And so when we work in these smaller geographic units, we can produce information that's you then append to your grant application, that we disseminate in all sorts of ways that are useful. That even just leads to more conversation. So this member checking we're doing this weekend at the Park District in Little Village, we're doing again at the library and again at a church within the next 2 weeks. So really this is what we found. What do we have right? What do we have wrong? What more do we need to know? And so we probably will hear that we missed voices in Little Village, and we'll say, yeah, well, we only had 14 weeks, and we had basically had no money. So we did 6 focus groups. You're right, that doesn't at all really capture the voice. So advise us, what would be next? How might we best reach these voices? And what we often hear too is, so you reach the group of moms who are already getting together on behalf of a running club. That's a pretty engaged group of women who are engaging in health behaviors. What about the mom who's not coming out of her house because of language barriers and fear of deportation and fear of violence? And I don't know the answer to that. I mean, that really is, well, we need some advice. How would we reach that population? Is that amenable to a focus group, or is that an interview? Is that a woman that we really need to sit down with? And of course, half of our research was conducted in Spanish, because this is see, and now the numbers are out of my head already. 40% of residents in Little Village, Spanish is a first language and their predominant language. And what we've learned through the focus groups is, because of that, there's very little movement outside of Little Village, because needs are really met in Little Village in terms of accessing services and schools. And so that leads to this quite homogeneous group of people who then has some very favorable health outcomes, but then have some negative health outcomes that we want to address too. Yes.
Can you talk a little bit about how partnerships were developed? Then you showed progress,
Yeah.
but were there barriers to developing those relationships with those partners, or did they jump on board immediately?
Yes. So great question. Her question is, how did the partnerships start? And they started in a really interesting way, actually. Although what I described to the students is that the students don't get to see the partnership development piece, and that's the most important piece. And part of it is gaining the trust of the community organizations to work with the University of Illinois at Chicago, some of whom haven't had the most favorable experiences working with professors and students. So, but this particular project emerged because a organization in Little Village, a faith-based organization, called our division, I'm in the Division of Community Health Sciences, and said, I think we have increasing rates of infant mortality. Can someone come help us think about this? And actually, they didn't call me, but someone mentioned it to me, and I was like, I will. And because I was really interested in, this is what community-based participatory research is, when community members or organizations identify the problem. You know, and I'd never honestly been privileged enough to be asked in that way. And so I said, I will. And so I pulled together a group of students. This is way before I started teaching this class, so kind of through an independent study. And we started looking at the data. And it turned out that their infant mortality rates weren't going up. You know, they have pretty favorable infant mortality rates overall, and they've actually been going down. But what had been happening is that this church in Little Village, the burials were going up. And so we looked at burial data, and so we started to come to the conclusion that despite the fact that the rates of infant mortality are going around, if burials are going up, that has a negative impact on the community. That is overlooked because who looks at burial data at the church level? I mean, I'd never seen these data before. And so from there, we started talking about why. Why are burials going up? Now, one of the, and those of you who are experts in the faith community know that people don't attend their church solely based on proximity. So they had people coming from Indiana to their church and using this church for burial services. So they drew from this huge catchment area. And that made us start thinking about, well, what's happening? Now, in some ways, that research question is beyond our scope. How, could we possibly discern the causation of increased burials at this one church? But it made us interested in the cause of infant death, something that we shouldn't tolerate in the United States and that this community overall has seen kind of favorable outcomes in. And so we started conducting interviews and focus groups, the students and me, in partnership with this faith-based community, on why. What do you think the reasons are? And what do you think we heard? The reasons for increased infant deaths in the city of Chicago among the Mexican immigrant population. What's that? Crime and obesity? Is that what you said? Uh-huh. You know, what we find is that the longer immigrant population, particularly Mexican immigrant populations in the United States, the less favorable health behaviors they engage in, so smoking, alcohol and drugs, risky behaviors with respect to obesity and heart disease, and their health outcomes generally get worse. But talking to the, in doing interviews and focus groups, the two issues that came up that were unanticipated from our perspective were stress, 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 stress. Daily stress, very real stress of fear of being undocumented and being deported and breaking up of our families. And that daily stress led to truly not going out the door, or very limited going out the door. And then issues related to domestic violence. So, you know, we're really careful to talk about what's causal in these things, but there's an increase in deaths in this faith community that they were concerned about. And when they talked about what are the roots of this, it was stress and what I would call gender discrimination. You know, that women who needed to seek prenatal health care and needed you know, high quality health care weren't seeking it in the ways that they would like because they needed permission from the male partner in their house, which is a cultural norm that was brought to the United States that they were experiencing a lot of conflict with this cultural norm. And I think that led to some recommendations to providers too to be more sensitive about this, because I think women, once they seek care, kind of get the finger wag that you should have been here before, not understanding how hard it is for that woman to seek care. And then related to stress is mental health, and this actually is come from the youngest youth to the oldest person that we talk to. So true, I think, mental health crises. So we had some of the youth, the males, talk about post-traumatic stress syndrome. I always get that wrong, PTSD, right? Basically saying that this is a reality that they live with every day, because all of the youth we talked to had some exposure with violence, some proximity to a shooting, someone knowing someone was shot, and that they very much feel like they have mental health issues that need to be treated. And while the services exist in Little Village, the taboo and the stigma to getting there are just too great. And actually, the services are there. We would from afar call them culturally competent services too. There's really these community providers trying really hard to be available to this population, but that the taboo, the stigma is just too great for any of the populations. Okay, so that's actually, these are pictures of my students. As the data's kind of coming back, we throw it up on a whiteboard and we kind of try to make sense of it, recognizing all sorts of issues related to power and privilege, including the fact that we're privileged to be in a classroom at UIC and School of Public Health and think about these things, and that we don't have all the insider knowledge we need on this. So we bring a lot of what we're finding back to our community partners to say, does this make sense? Have you heard this? But we also, because we love technology and we wanted a greater reach, put together a community health survey and put it online, as I said. And that has been like the greatest failure that's ever happened. There are 79,000 people in South Lawndale Little Village. 9 of them have filled out our survey. And from the very beginning, to be honest, our community partners were like, it's not going to work. We have put it in the ESL classes. We've made it available in the library portals. It's in English and Spanish. But it's the interface of data collection that our community partners were like, if you sit down with this person and walk them through it. So we're learning from that. It's still out there, and we're going to present what we like to say an N of 9 this Saturday. We'll probably get laughed at, but we have to figure out how to use survey research methodology. We were interested actually in 2 core things in addition to kind of community health broadly, and that was the experiences of discrimination, perceived discrimination, and then this gender discrimination. And our community partners said there is no way you're going to get valid responses on a survey question. To what degree do you experience discrimination on a daily basis? And they were just like, that's a silly question. Okay, I'm out of time. So thank you very much. Good luck with all of your projects. I think I have the pleasure of coming back to you guys in June after my community health assessment's all done. So thank you.